70 years ago, the People's Republic of China was founded, marking the end of over 100 years of invasion and oppression. 70 years on, under the leadership of the Communist Party of China, China is now the world's second largest economy, engaging actively with almost every country on Earth. In this special series, we explore China's development over the 7 decades, from political and economic development to diplomatic and military evolution. What are the theories and events that have shaped China's past? What are the trends and challenges that will forge China's future? I'm Robert Lawrence Kuhn. I've been coming to China for 30 years. I've witnessed astonishing changes. What do China's changes mean for the Chinese people and for the world? Watch our special series on Closer to China, 70 years and counting, China's new era and beyond. Eliminating poverty, improving people's livelihood, and gradually achieving common prosperity are what the Communist Party of China, the CPC, calls the essential requirements of socialism and its sacred mission. Since the 18th CPC National Congress in 2012, the party Central Committee, with General Secretary Xi Jinping as the core, has made poverty alleviation a key benchmark for achieving a moderately prosperous society by 2020. At the 19th CPC National Congress in 2017, targeted poverty alleviation was specified as one of China's 3 tough battles. According to China's National Health Commission, at the end of 2018, there were still 16.6 million of the population living below the poverty line. Among them, the proportion reduced to poverty or returned to poverty because of illness is as high as 40%. Thus, poverty alleviation via health care has become a primary focus of China's fight against poverty. What are the major challenges? What strategies are being deployed? What has been achieved and what changes have occurred? For rural health care in the new era, how will China address new problems? Overall, what is it about poverty alleviation in healthcare that has Chinese characteristics? And why is it so vital for the CPC? We find out to be Closer to China. Her name is Guan Yanping. 3 years ago, she was an attending physician at Sanzhao Hospital in Zhuhai City. In 2016, with the launch of the program Medical Assistance Between East and West, Jinwan District cooperated with Gongshan, one of the counties in Liju Autonomous Prefecture of Nujiang, to send the first team of assistance personnel to Gongshan on a mission of poverty alleviation via healthcare. Guan Yanping was one of them.
我呢也刚好是觉得自己的条件还是蛮符合的，又想到当时没想到这边这么艰难和这么条件这么艰苦，只想着说啊，既然是要求帮扶的话，就可能这边就更需要，所以我也想着我的工作年限也比较长了，当时也20多年了啊，所以就想着报名参加。经过我们院里的选拔和区里的选拔，层层的选拔，才可以派生过来的。
She was stationed in Binzhongluo Township, located near the southwestern border of China. Binzhongluo is an area designated as extreme poverty, with backward infrastructure and scarce natural resources. Of its population of 6,300, nearly 1,000 are living below the national poverty line. Among them, about 150 are living below it.
2017年时候，这里的村民健康意识和健康状态相对来说还是就是比发达地区比我们那边是相对就是有很大的差距。那他们当时那种状态，就是说疾病也是蛮多的。脱了鞋。
In the town hospital, there are fewer than 20 medical staff. Dr. Guan is an experienced physician. Naturally, she has much to do here. Daily consultation with patients, using medical equipment, training local medical staff, recording health files, and handling first aid, all are her tasks. To assess villages' conditions and to provide proper medical assistance, Dr. Guan will traverse hills and climb mountains. 15 kilometers to the north is the northernmost village of Chonan-tong.
王宝文，哎，在家啦？哦，我还说下雨在躺着呢。哦，不错嘛，今天把雨伞放下啊。我还说在没在家，我给你助行器回来了，看一看。这个脚动一下。这个。
He Baowen, a veteran, is 37 years old. He seldom speaks. 2 years ago, he suffered a stroke, leaving parts of his limbs paralyzed.
一放松就全打开了。最开始还记得吗？我来看你，床在这边啊。躺着呢，大小便都在床边，臭臭的啊，起都起不来是吧？现在好多了啊，真不错，真好。
In his family, He Baowen has elderly parents to support and one child under 6 to raise. But after he became ill, there was no one in the family who could work. If such had happened in the old days, the family would have collapsed. 上一次的血压还不高，今天为什么血压会高了一点点呢？最近休息不好吗？
挺好。
都好啊，再监测一下啊。
This kind of follow-up examination often lasts a full hour. Measuring blood pressure and blood sugar, physical therapy, all the routine protocols and procedures one would expect for a recovering patient.
放下，站起来。这会儿拿扶着，站，扶着这个。哎，对，这个手一起，那个手扶那儿，拿俩手一起，对，抓上。对了，以后就这么练，啊，是不是稳好多？哎，好好练，又稳了，不怕摔跤啊。
In the words of Dr. Guan, getting to know her patients and helping them build self-confidence is vital.
来，坐在这儿，我给你放在这儿，冷吗？放在这儿啊。
有点冷。
有点冷哈，来脚底下啊，这个人字就2个大小一句啊，这个人字中间这个位置啊是涌泉穴啊，要按这个啊，也是。有轻的重，女的。
Exercise impacts our physical health, as does diet. Due to a language barrier, however, Dr. Guan can explain the food recommendations only to He Baowen, who will then relay them to his mother later.
你告诉你妈妈啊，给你们做饭的时候一定要做的清淡一点，不能太咸太油啊。一天一个人的盐量不能超过6克，那么1小勺，啊。
After 2 years of follow-up, He Baowen is gradually emerged from this difficult period. His life began anew. He has access to seeing a doctor, and a fair percentage of medical fees can be reimbursed these days. With flocks of chickens, ducks, and geese, crops planted on a few acres of land, and a good subsidy for low-income families provided by the local government, he feels content.
记得要好好的锻炼啊！有空我下次再来。
It's 4 o'clock, but today's work is yet to be finished. 8 kilometers southward along the Nujiang River, we reach Wuli village. Here, according to the schedule of services and a contract that was signed between local doctors and the villagers, 2 households still remain to be visited. However, the road into the mountains is in poor condition and hard to pass.
当时我们来的时候，真的是又窄，弯路又多。左边就是立陡立陡的悬崖，下面是滚滚的怒江，然后右边也是立陡立陡的悬崖，是高高的山，看到一直到天顶那种。这个地方泥石流经常会发生，一冲的时候就会把电网冲垮，冲垮了以后就会紧接着就会停电、停网，就是手机啊、信号啊什么都没有。 有一次停了1个多星期，将近10天，家里人就打电话，怎么打也联系不上，他们就着急了。第一次的时候，等我们恢复了以后，再看手机啊，一下子有上百个电话，真的是都是未接电话。小的时候读课本的时候说，大山里的孩子说天天看着这座山，望着另一座山，就是说走不出去这座大山。现在我们。 你真正走到这里的时候，就完全能体会到这些深山里的孩子们有多艰难。看这不可，等一下，让他学一学嘛。哎，那怎么办呢？真的是找不到。他能去哪儿呢？ 来帮扶，其实最不舍的、最放心不下的还是老妈妈了，而且也感觉对她还是一个愧疚。她一直就是盼着我能回去，早一点回去，能带着她出去走一走。她身体不好嘛，年龄又大。
After staying the required 6 months at her remote assignment, Dr. Guan then chose to not leave, but to stay on. Most people would be surprised by this.
老百姓对你那种依恋和依赖，而且对你那种信任，让你真的有一种很不舍，就想着能多待一段时间，能在这里头继续把你想做的事情再多做一些，可能这个延续性就更好一些。不是其他的同志来了不能做啊，其他的同志来可能。 又需要一个了解和磨合一个过程。
For over 2 years, with rucksacks of medical equipment and medication carried on their backs, the remotely stationed doctors traveled deep into the mountains over and again. Thanks to their dedication, the poor people who have lived here in these mountains for so long are slowly stepping out of their healthcare haze, where previously disease diagnosis was unknown, treatments were inaccessible, and fees were unaffordable. The dispatched doctors, on a larger scale, the entirety of the medical assistance program, is only one part of poverty alleviation in healthcare. In China's poverty-stricken areas, many new initiatives are in operation. At the beginning of 2019, there were still 16.6 million people living in absolute poverty in China. What is it about this final group that makes those people so intractably poor? The phrase hard bones is used. What's the meaning of that, and how can we understand this final group to be brought out of poverty?
When China started its targeted poverty alleviation, roughly 40% of the impoverished population was reduced to poverty due to poor health, including illness and disabilities. Responding to such a high percentage, the Chinese government, starting from 2014, initiated the policy of poverty alleviation in healthcare. It is, in fact, to tackle illness-induced poverty with a series of interventions.
Poverty alleviation in healthcare represents a crucial link to China's poverty alleviation strategy, which also draws close public attention. In a nutshell, it covers 4 aspects. First is affordability, to guarantee the basic medical needs of the poor population and ensure affordable medical services. Second is quality, to ensure basic treatment and management services for people suffering from illnesses. Third is accessibility, to improve our medical system at the village, township and county levels, to ensure people can receive local medical care. By extension, that includes curing minor ailments at the town level and serious illnesses at the county level as our goal. Fourth is prevention, to raise people's awareness and keep people in good health by diagnosing diseases in their early stage and combining prevention and treatment, and that is a critical factor. Each of us serves as the principal caretaker of our own health.
According to the State Council Leading Group Office of Poverty Alleviation and Development, among all registered poor households, those who are illness-induced into poverty are as high as 42% or even higher. This is especially true in the 3 regions and 3 prefectures. These are the Tibet Autonomous Region, the Tibetan regions in 4 provinces, the southern parts of Xinjiang Uyghur Autonomous Region, Liangshan-Yi Autonomous Prefecture in Sichuan Province, Nujiang Lisu Autonomous Prefecture in Yunnan Province, and Linshahui Autonomous Prefecture in Gansu Province. Illness has become the biggest obstacle on the road to poverty alleviation. Following the 2018 decision by the State Council, the National Health Commission issued a 3-year action plan under which targeted measures were carried out to help speed the pace of poverty alleviation in healthcare. You've described a systematic approach to healthcare and poverty alleviation. How did that system come about? How was it developed over time?
Poverty alleviation in healthcare requires efforts from both the supply and demand sides. Treatment and prevention are equally emphasized to ensure basic medical security to prevent illness-induced poverty. The first is from the demand side, establishing a multi-layered and wide-ranging medical security system to guard against illness-induced poverty. The impoverished population is subsidized to join the basic medical insurance plan, and the security system is further established with various forms of supplementary insurance and charity. Meanwhile, China has implemented a policy of treatment before payment and one-stop reimbursement for rural poverty-stricken inpatients at county-level hospitals, making the healthcare services affordable. The second is from the supply side. We aim to improve the quality of medical and health services by upgrading medical standards and increase capacity. We have invested heavily in the standardization of medical and health institutions at the village, town, and county levels to transform the medical services for poverty-stricken areas. To raise the quality of medical services, we mobilized 1,007 tertiary hospitals to assist 1,172 county-level hospitals in all poverty-stricken counties across the country. Medical assistance is organized in groups. Experts are dispatched to be stationed in county-level hospitals to help local hospitals strengthen the development of clinical services for the local variety of diseases. The third is targeted treatment. We register households reduced to poverty due to illness in a detailed information system, after verifying their conditions, and offer them targeted treatment. Today, we have listed 25 major illnesses that are costly but with obvious therapeutic courses of treatment. Patients suffering from the listed illnesses have all received due treatment. For those with chronic diseases, they're motivated to sign service contracts with doctors at township and village levels. Thus are regularly visited and offered prescriptions under standardized management. And fourth, we have integrated preventive and curative care for epidemic and endemic diseases to improve people's health condition. The targeted treatment has been applied to diseases like AIDS, echinococcosis, and tuberculosis, and we have adopted measures suited to local conditions. The government has implemented major public health service projects. The people are mobilized to carry out health promotion programs to foster a healthy environment.
Where do you see the biggest challenges or problems in each of those 3 areas? Where are the difficulties?
China faces not a few challenges on all fronts. For example, we face 2 dominant problems in improving medical conditions and service capabilities in poverty-stricken regions. First, it is not economical to build a health center in a sparsely populated village or town. Second, for poorer regions without doctors, Where local conditions are poor and actual demand for doctors is low, it is hard to keep a qualified doctor in the village. Besides the shortage of medical professionals, it takes huge funding to treat major diseases, provide contract guarantees for chronic diseases, and minimum living allowances. In the short term, the government could foot the bill, but some local governments have their own difficulties. More importantly, even with patient out-of-pocket costs being a co-payment of less than 10% of the medical bills, for a major disease that might cost $30,000 to treat, then 10% of that means $3,000 in patient copay. That expense is astronomical for those poor households. That is to say, even when we carry out the strategy of poverty alleviation in healthcare to its full potential, there still will be a portion of poor households facing daunting economic pressure. Third, as for the publication of the prevention of endemic and epidemic diseases, speaking frankly, some endemic diseases are linked with the long-term living habits of ethnic minorities. It is difficult to guide them to change their habits that have been in place for hundreds, even thousands of years.
Healthcare is different than industry in the sense that industry, if people have a business, it can continue. But with healthcare, people who are well get sick. We all get older and new problems emerge. So how do you deal with the continuing effort to keep all people, providing them proper healthcare even if they're in poor areas?
The Chinese government has long recognized that problem and basically resolved that issue. How did we do it? For young people who get ill after receiving medical assistance and getting back to health, we support them to engage in industries to earn a living. Surely there are people who suffer from chronic diseases like mental deficiency and geriatric syndromes, which we provide regular medical assistance to follow-up visits. For those who lost their labor ability as a result of aging or disease deterioration, the government offers them minimum living allowances to ensure lives of dignity.
In China's remarkable efforts to alleviate poverty through health care, what would you say are the specific Chinese characteristics, the differences that are occurring here in China in health care for poverty alleviation that is different?
In the past, the Chinese characteristic was mainly reflected by government investments and policies. Today, we have adjusted the one-way investment model with comprehensive assistance for poverty alleviation in health care. Only in this way can we expect transformations. The government used to spend money introducing equipment to county hospitals, but that didn't work without medical professionals. Besides, how can we make the equipment affordable to the poor? Some county hospitals introduced CT scanning, but the poor couldn't afford such services. Now, the poverty alleviation in healthcare in China features the government's leadership and participation in social organizations, with entrepreneurs, in developed regions, with philanthropists, and with non-governmental organizations.
Amid the poverty alleviation in healthcare, we have taken full advantage of the features of China's institutions. The methods we adopted are in keeping with those in targeted poverty alleviation. Governments, medical departments, and hospitals at all levels must sign letters of commitment with their corresponding upper-level government and hospital that designates specific responsibilities in the village clinics, townships, healthcare centers, county hospitals, and governments. Their goal is to reduce within a certain year a specified number of poor households that are receiving healthcare services, and the government agency will be held accountable for that. In my opinion, the monitoring and appraisal of healthcare assistance programs in other countries may be more at the technical level, while in China it is at political and accountability levels. In other words, the responsibilities for poverty alleviation in healthcare are secured with strong binding power.
In the run-up to 2020 and the target of eliminating all extreme poverty in China in our sights, there's great enthusiasm and great national commitment to do this. But I'm wondering what happens after that. What are the thoughts going forward? How do you sustain healthcare and poverty alleviation? And what do you do with those who fall back?
那么我们现在主要的考虑啊，主要还是这个3个方面。
Currently, our main considerations can be summarized in the following 3 aspects. First, it is to be linked with targeted poverty alleviation strategies and set up a long-term guarantee instrument that will further facilitate a long-term method to guard against poverty due to illness. These are the experiences brought to us by transforming both the supply and demand sides. Next, we're to build a longer-term means to tackle the issue. Second, we're to integrate poverty alleviation in healthcare with the deepening of reform of the medical and healthcare systems, particularly the reform within the counties. We have successfully delivered basic medical security for the poverty-stricken population. Next, we aim to upgrade the service quality, which takes reforms and development measures to constantly improve the medical and health service capabilities at the county level, and further improve people's sense of gain in terms of health. Third, it is to be integrated with the ongoing Healthy China initiative. By promoting healthy diets and health facilitating programs in the countryside, we're to build a long-term mechanism for eradicating dangerous factors to health and recognizing and preventing risks at an early stage. Thus, we will suppress the recurrence of illness-induced poverty. By doing so, the physical well-being of the rural population is to be enhanced. Until now, we have been focusing on these 3 aspects. During the process, we're constantly adopting targeted measures to make our efforts more effective.
For China, implementing poverty alleviation in healthcare is a significant component of China's overall commitment to eliminating all absolute poverty by 2020, ushering in the moderately prosperous society. Healthcare institutions in poverty-stricken areas have been improved. Treatment of disease has become more timely, and medical expense burdens of poor families have been abated. From 2013, when the concept of targeted poverty alleviation was first introduced, to the end of 2018, 6.7 million registered poor households in China have been lifted out of illness-induced poverty. Still, problems in realizing basic medical care in areas of extreme poverty remain. In my view, medical institutions are not that advanced, healthcare facilities are not that adequate, and some medical workers' skills are not yet improved. Moreover, endemic diseases in extreme poverty areas, such as Lisu Autonomous Prefecture of Nujiang, are persistent, such that disease prevention and control is arduous. And regarding medical insurance, a misalignment between high medical reimbursement and overly broad classifications encourages excess medical treatment, which puts greater pressure on medical funds. How will China balance healthcare quality and healthcare costs in poor rural areas? How will China sustain healthcare in poor rural areas and avoid poverty recurrence? We track the problems with the achievements to be closer to China.